We will now move on to our next speaker, Dr. Ravul Jindal, who will be updating us on the management of varicose vein.
Good morning, everybody. Thank you, Dr. Jain and Dr. Mukherjee, for inviting. And happy Doctor's Day to all of you. And today is a very important day, and as you all know, it is because of Dr. B.C. Roy. He was from Calcutta. And, so it's a very, very important day for everybody. We're going to talk about what are the basic treatment options what we have available for varicose veins. So, SEEP classification. So this means how do we classify the patients in different groups? Because there could be one doctor treating a very early varicose veins and the other doctor may be treating an advanced. So how do we compare it? So that's the basis for this classification. So what that means is if you have a C2, that means a very early varicose veins, as compared to C6, where the patient has got an venous ulcer. So the treatment, whatever we are doing, the basis is that the patient should not get a venous ulcer. So that's what we want. So all the things what we are doing today is to prevent a venous ulcer. Now there are various treatment options as you can see from here, and we're going to go one by one. Besides compression stockings, which should be given to all the varicose vein patients, but it should be absolutely clear that compression stocking does not prevent recurrence of varicose veins. So it's a lot of myth is there that if you keep on wearing stockings, you will not get varicose veins again. So the new nice guidelines from UK actually does not prescribe you compression stockings. So they say if you have C2, C3, C4, so then you directly go for an intervention and you don't require a long-term stockings. Second option is a surgery. Can I have these lights off? Thoda kam kar doge light. Then the second option is a surgery. Now the surgery can be done with local anesthesia. So modified surgery is we do it under local anesthesia, mark the vein on ultrasound, and we operate, and the patient can go home on the same time. So it is similar to the laser. So what we call a modified open surgery, and along with the foam sclerotherapy, we can get a very good results even with an open surgery where the laser facilities are not available. In terms of laser, we used to use 1470 nanometer. So the new advancement what has happened is 1940 nanometers. Ye theek hai. So what has happened is, what is the wavelength? So the laser works on the basis of wavelengths. So the higher the wavelengths, the better penetration into the vein wall. And actually talking, it is much safer. It gets more absorbed by the water molecules of the vein wall. So you get less hematomas, less pain, less cord formation. So there are different type of laser fibers: single ring front, single ring, double ring, 5 ring fibers. So basically there are studies which shows that there is not much difference if you use radial fiber, and in terms of rings there is not much difference which is available. So imagine a patient, huge varicose veins patient has got here from top to bottom. As you can see, skin changes. Then under local anesthesia, you put in a 6 French sheath here, a laser fiber, and on table, along with laser and foam, you can get a fantastic results within 15 to 20 minutes. So that's the beauty of the non-invasive treatment for varicose veins. So once you see the patients being done with this treatment, you will not do an open surgery ever, actually. Then we also have something called thermal crossectomy. What that means is, just like an open surgery, you used to do the ligation at the SFJ. So this is the common femoral vein, long saphenous. So in laser, we go only up to this point. So what used to happen was, if this valve is not functioning, then the blood used to go from here into the epigastric vein. And patient used to have recurrence. So the new thing what is people are recommending is that rather than ligating here with the laser, we do up to ablation up to here. And of course, if you go take the laser fiber up to there, what will be the risk? There will be risk of damaging the deep vein and causing the deep venous thrombosis. So we still don't have the jury out. So in some cases we do this, but not as a routine. So this is just an example. How do you take the laser crossectomy? You take the laser fiber up to that point, common femoral vein, take the laser fiber there and burn it. And you can get a very good results. If you check the flow on the Doppler, the whole of the vein is closed up to the SFJ junction. Then we have a perforator closure. So in some patients where there is a pathological perforator is big, at the base of the venous ulcer, you close them either with a foam or laser or radiofrequency or glue. So you can use either of the four technologies. So here just an example where we use the bare fiber through an 18 gauge Venflon, and you can use put a tumescence here, that's the deep fascia, and that's the laser fiber, and you can close the whole of the vein with a laser fiber. We use normally a bare fiber because it can have a very small hole, but you can use a radial, but then you have to use a 6 French sheath. You can also use a radial, which is a thin fiber from a smaller sheath. Then we also have a radiofrequency ablation. There are various machines which are available in the country. This is one from the Medtronic. It works on the similar pattern. Then we got a steam ablation. There are some studies published, but there are not too many long-term results, so it never picked up in the world. Then newer technologies is the microwave. So we are using lasers, but they're all burning the vein, and we are blocking the vein. So you can use different energy. So why microwave was discovered? You see, in some countries in like Europe, because the type of laser what we use is the type 4. So it is very risky. So there are some countries like Germany, they've got a very, very strict protocols for using the laser, very strict. We use the laser just like that. But if you have to use the laser over there, you have to have a lot of protections, a lot of, things to be done, protocols to be followed. So a lot of hospitals say, why to go into the hassle of having these laser protocols? Let's use a radio frequency or a microwave. So microwave, we have been using it for nearly 4 years now. So it's a good technology and it's showing a good results. Then we have non-thermal techniques like a MOCA here, a glue, and a foam sclerotherapy. So MOCA is, we scrap the inside of the vein and we use a liquid or a foam sclerotherapy. So why this technology? Because no need for local anesthesia. You can use this technology in the peripheries. It's very quick. And even the people who don't have, monitoring machines and everything, they can still use it. And so it's a good technologies. But what is the drawback is the long-term results are not good. So we had our patients 3 years follow-up, and 30% of the veins, they opened up. So that's why, so what we do is we open the blades here, and we scrap the vein, and we inject the foam. So foam basically causes a blockage of the blood vessel. So we scrap and inject foam. So that's a thing. So this technology should not be used as a routine where you want to get a very good results, because laser and radio frequency can get the results up to 99% closure rate, nearly 100%. So we can get a very good results initially, but the patient can have a recurrence. Then glue, there are 2 glues which are available. Turkish glue is now less available in India. Medtronic glue is there. So basically we block the blood vessel again. There are some differences in the glues. We will not go into detail, but glue is another very good technology, and it has got a very good closure. And the advantage is you don't have to use local anesthesia. But the drawback is it's very expensive as compared to laser ablation. So then we have got a newer technology, the last technology is a high intensity focus ultrasound. We use it in thyroid, fibroids, everywhere. So basically from the top of the skin, we don't inject, so we use an ultrasound, very high intensity, and burn the vein from the skin. Now this is still in the experimental stage. There has been more than 50 patients which has been operated with 6 months to 1 year follow-up, and it's showing around 90% closure rate. So it is an evolving technology at present, so it's not available everywhere. But in the future, if this succeeds, we'll be seeing this technology more and more. Coming to cosmetic varicose veins, we have in the skin telangiectasias and the reticular veins. So like these small ones, so these are treated only for cosmesis. So we can use various technologies in this, a very dilute sclerosant or a transdermal laser like an ND-Weig laser we can use. So there is another technology called as CLARCS. So basically it's a very propagand from Brazil. So where we are using the laser from the top and we are injecting dextrose 75% into the veins and under a tumescence. So we are going to show you this, how we do it. So this is our laser machine in our, and this one is the laser machine, ND-Weig 1074, coolant, and this is our room in the hospital. And so what we are using is, can you see the red spot here? That's a laser, that's a vein we are treating, and this is a vein illuminator. And this is the coolant, we are using the coolant here. So what we are doing is, from the skin, we are damaging the vein. And this is a particular wavelength of the laser which is damaging. So there is no scar, no clicks, and then we use a 30 gauge needle to inject into the vein, and you can see the vein getting disappeared as soon as you inject. The advantage of this is it's very neat, it causes less hyperpigmentation and gives a very good long-term cosmetic results. So we use it especially for face veins, foot veins, hand veins, and in the foot and the legs and everywhere, wherever you need a very good cosmetic results. So you can get a very nice cosmetic results on the legs here. The last topic is the bulbar varicosities, what we call pelvic congestion syndrome. So you can get hugely dilated veins in the pelvis. So either you can use a sclerotherapy, or sometimes there is an ovarian vein reflux from the top. So we have to go from the internal jugular vein into that ovarian vein here, and then we can use either the coils of foam or glue. So you can see we have put in a lot of coils here, and so nowadays we treat them with the glue because it's much cheaper and can get a very good results. So in conclusion, treatment for the management of veins is really evolving and is very, very patient friendly. Nearly 99% of the patients can be discharged within 1 hour, and minimal invasive treatment is a very good treatment. Thank you.